This is Precision, Perspectives on Children's Surgery from Ann and Robert H. Lurie Children's Hospital of Chicago. I'm your host, Erin Spain. On this podcast, we introduce you to surgeons at one of the country's most renowned children's hospitals to find out how they're transforming pediatric medicine. For children needing a new liver or kidney, the greatest hurdle can simply be finding a healthy organ that's available for transplant. But while organs of deceased donors are extremely limited, living donors can offer pediatric patients a chance at life. Lurie Children's Living Donor Program is the largest in the region, thanks to a partnership with Northwestern Medicine. The decades-long collaboration means both adult organ donors and pediatric organ recipients receive the best and most comprehensive care possible. Doctors Juan Caicedo and Dr. Satish Nadig, adult and pediatric transplant surgeons at Lurie Children's and Northwestern Medicine, lead this joint effort. They join me to discuss this uniquely robust program, which has completed more than 1,700 solid organ transplants since its inception and ranks among the highest numbers of pediatric organ transplants in the country. Welcome to the show.
Thanks, Erin. Excited to be here.
My pleasure, Erin.
Before we talk about the success of this unique collaboration between Lurie Children's and Northwestern Medicine, let's first talk about living donor organ transplantation in pediatrics. Why might pediatric patients be in need of organ transplantation, and why are living donors so crucial when it comes to pediatric care?
Depends on what is the organ is needed, the causes are different, right? And also depends on the age of the kid. If we talk about kidney transplant, maybe the reason is a genetic issue, a metabolic issue, or there's a glomerular diseases when they are older that can cause the problem, or there's some systemic diseases that can cause problems on them. If it's patients that require liver transplant, depends on the age too. The most common cause is biliary atresia, when the biliary system doesn't develop, but also there's metabolic diseases, there's tumors, and some patients need a small bowel transplant or multivisceral transplants, and because the bowels are not working, they are damaged because congenital diseases or because they have lost a bowel due to development diseases, or there's a functional problem with the bowels, then they eventually will need a transplant.
Thankfully, there are not as many children that need life-saving organs as there are adults in the population. But when they need them, they need them. And we often are up against constraints of size that we aren't necessarily up against those constraints in the adult population. Oftentimes also, when children need them, they have progressively worsening disease processes, especially when they have liver failure. And we don't often have time to wait for organs that could become available through the deceased donor pool, which is the most common way that we do transplant people. So we look to living donation.
The living donors are often adults, they're family members, sometimes mom and dad or relatives. And this makes this partnership between Northwestern Medicine and Lurie Children's so important. Tell me about the comprehensive care that you're able to offer both the living donor and the child receiving the transplant.
We are working together. It's not only about the child, but it's also about the family and all the social support network that they have. And then we have to help all of them. This is a very important partnership because the transplant in the kid will happen in Lurie Children's Hospital, but the donor operation and all the pre-donation evaluation, the surgery and the follow-up of the donors is going to happen in the adult hospital. Then this is essential to have a coordinated efforts between both the pediatric hospital as well as the adult hospital. Then basically we have a big team in both programs, in the Lurie Children's Hospital as well as Northwestern Memorial Hospital, where we work together to evaluate. Then when we evaluate donor and recipient, it's kind of similar in a way because we want to make sure, first of all, that there is no medical, surgical, or psychosocial contraindication for the recipient to undergo the transplant as well the donor. And specifically about donors, we want to make sure that even though everything in life is a risk and donating it as a risk, if we have a thorough evaluation, we minimize the risk as much as possible to be able to have the best outcome, not only in the recipient, but as well in the donor. The safety of the donor is essential, and we want to make sure that all donors will recover well after donation and they can have normal life, they can work, they can exercise, they can eat whatever they want, they can return to the daily activities and all normal life that they have prior to donation. That is at least the goal.
For people who don't know, these two hospitals are literally across the street from each other. Explain that proximity and what an important aspect that is in all of this.
Well, we're connected through bridges and all indoors, and our operating rooms on the Northwestern side. We work closely with our organ procurement specialists. We remove the organs and literally walk them over to the operating room on the Lurie Children's side. What that does is decrease the time that's out of the body. And so that's called ischemic time. And it just improves our quality and improves our outcomes.
What makes someone a good living donor and what might exclude someone? You mentioned a few things there about the general health of the patient, but explain that to me.
Usually is adult people, they're older than 18, don't have any medical comorbidity. And more important, actually, we want to make sure that is a voluntary decision without coercion. They now will start evaluating if there's any medical, surgical, psychosocial contraindication. Then in the medical standpoint, we want to make sure that there's no infections or cancers or cardiovascular diseases or metabolic diseases that could be a contraindication. In the US, as most of the population is obese or overweight, 60-75% of the population, there is a risk factor for potential diseases in the future. Specifically for liver donation, if people are obese, there is a high chance that they will have fatty liver disease, and then maybe they can donate. Although I have to say, obesity is a relative contraindication because if people lose weight, they can improve the health and then eventually can donate an organ. I can mention one of our donors lost 120 pounds before it was able to donate her liver. Then obesity is a relative contraindication, but of course that doesn't happen overnight. Then we want to make sure there's no cardiac problems and psychosocially make sure that they are sound, that there is no psychiatric diseases that can affect the recovery of these people. They are always wonderful people, and we want to guarantee or be sure as much as possible that they are going to be okay after donation.
There's also that compatibility issue. Can you talk about that?
One compatibility could be the blood type, for example, for kidney transplantation, but there's the immunologic compatibility, HLA, how much the donor recipient share. Sometimes the donor can have antibodies against the recipient cells and can attack and can generate rejection. But if they are very compatible, for example, if a family member or a sibling, maybe an identical twin, that means that immunologically speaking, they are the same. Even though they're a different person, immunologically speaking, they can be HLA identical. That means the immune system in the recipient is not going to recognize as different the organ that is receiving, and there's less chance to reject the organ and less immunosuppression will be required over time. Here at Northwestern, we have done a lot of transplants. As a team in both hospitals, we have done more than 7,000 kidneys. For the liver transplant, we have done now 3,000 liver transplants as a team, more than 2,500 adults and close to 500 kids. Even though always we say in transplantation, compatibility is important, and it is, but sometimes we can go even against compatibility and make it work. Then for kidney transplantation, we can do ABO incompatible and highly sensitized patients, or we can do swaps, kidney pair donations. For livers specifically, for example, in kids, small kids below 2 years, we can do ABO incompatible very successfully. Then depends of the organ and depends the age of the patients, we can go even against a blood type and do an incompatible transplant. But again, most of the time, if it's possible, we want to have a compatible organs, make it easier and minimize the risk in the recipients.
Which organs are living donors donating most often? Is it a part of their liver, kidney?
Then the most common organ is the kidney, followed by the liver. Then basically, we usually have 2 kidneys, and we can have a normal life with only 1 kidney, as long as we don't have any other comorbidities. We have only 1 liver, but the liver is a wonderful organ that even we can remove up to 70% of the liver in a healthy donor, and in 3 months, the liver will grow back to almost normal size.
You walked through a little bit some of the screening and evaluations that you do on living donors. But now this procedure, while it is so incredible and life-changing, it is still very difficult for the families and the children who are undergoing this. So tell me about this approach to care that you take when it comes to pediatric transplantation.
This is an emotional roller coaster, no question. From the moment that these patients and people get diagnosed with organ failure, it's an emotional roller coaster. And we can't get you off that roller coaster. And that's the first time often that they've been on that roller coaster. The good news is we've been on that roller coaster before. So we sit right next to them and tell them where the twists and turns are going to be. And that's the only thing that really can decrease your anxiety. So I tell people we can't guarantee 100% of anything in medicine. You just can't do that. But what we can guarantee you is that we'll be 100% honest with you. We'll take 100% good care of you by telling you where these twists and turns are going to be, because we have such a robust program. We have seen almost everything. And I never say everything because you never know. But we've seen almost everything with the experience that we have, that we can often predict the parts of the process that could go well and they could face, and studies that we would do, and the plans that we have that go all the way from A to Z.
We have to see the patient as a human being, and the family is the same, is beyond the organ. We have to consider their mind, their soul, their spirit. That's why part of the team is our psychologists, social workers, that's our psychiatrists, is not only surgeons, but is also the nephrologists, or the kidney doctors, the liver doctors, the gastroenterologists, hepatologists. And then all of us assess the patient, as well talk to the families, we educate them. There's a lot of education in our process. For example, before donation, before we evaluate them medically, we provide talks to them to set up expectations, to answer the questions. We have a lot of this information in the website. And this is no one-time event. It's a journey. Everyone in the team provide a lot of information, education, answer questions throughout the process.
And this continues really into adulthood for a lot of these children. You're able to transition them from being Lurie children's patients to, when they reach the teenage and adult years, Northwestern Medicine patients. Tell me about that transition.
The number one reason that adolescents lose their organs is because of non-compliance of their medications. And that is extremely important for us because it's preventative. Those are unforced errors. And why does that happen? Well, they're not in the childhood or the baby stage where people are administering their medications to them, nor are they in the adult stage where they understand the ramifications of their consequences and ramifications of their actions, nor the full gravity of what actions can do. So they truly need much more intensive one-on-one patient-centric approaches to their needs in that transition time. We recognize that, we realize that, and we have dedicated physicians that communicate with their physicians at Lurie's to have this young adult transition and care program so that we can make sure that the quality of their outcomes maintains when they come to the adult side. Because at the adult side, we do a lot more organs for sure. I mean, there's more adults that need transplants. For example, the United Network of Organ Sharing comes out with volume rankings, and Northwestern's the 8th largest transplant program in the country. We do close to 400 kidney transplants a year and close to 150 liver transplants a year last year. And we're the second highest pancreas transplant program in the country at Northwestern. When they come here, they're in a huge pool of people that all need specific care, but they need a little extra attention. And we realize that, and we put that infrastructure in place.
Another big differentiator of this program is that it's very culturally sensitive. Dr. Caicedo, can you tell me a little bit more about that?
For example, we have a dedicated program for Hispanics. We were the first center in U.S. who developed a Hispanic transplant program. Now we have been able to transplant here at Northwestern Memorial Hospital more than 1,500 Hispanics. We're able to improve access to transplant care of Hispanics by 91%. And we're able to increase the number of living donor kidney transplant in Hispanics in 74%. And we decreased the disparity between Hispanics and non-Hispanics, white, living donor kidney transplant by 70%. We were the only one in the country with this type of results, helping this community. Then this is a culturally sensitive approach. And as the Hispanic community is very family-oriented, We want to bring the whole family. We want to educate the whole family. When we resolve the questions, they're more willing to support the patient. They're more willing to help them. The outcomes are better. And many times they decide to become a donors. And that's why we have a Hispanic community here in our hospital, for example, has had one of the highest living donations rate compared with any other ethnic group. And this is the opposite to what we see in the United States. This cultural sensitive approach is really, really important. We also, at Northwestern Memorial Hospital, we developed the first African-American access transplant program that we're helping to remove all these mistrust, misconceptions to improve the care of this community. We really need to personalize the care of our patients, and that's what we do, and that makes the difference.
Dr. Nadig, tell me about your role at the Comprehensive Transplant Center at Northwestern University Feinberg School of Medicine and this approach that you have there called the Matrix Research Approach to Aid in Transplantation. What is that, and how does it benefit potential donors and recipients?
I'm the director of the Comprehensive Transplant Center, and I serve as the chief of the Division of Transplant Surgery, which means I oversee the entire transplant program here. But my job is super easy, honestly. I'm surrounded by really good people, a set of vision, and I get out of their way. That's my method to leadership here at Northwestern. And one of the ways we do that is we integrate all of our experiences and experts into this entity that we call the modular approach to transplant research by interdisciplinary experts, or the matrix approach. And Northwestern University and Lurie Children's are experts in something called immune tolerance. We have more patients off of anti-rejection medication than anywhere else in the world. Now, these anti-rejection medications are what people are suffering from, and often people die from after transplant because their organs are doing well, actually, but those anti-rejection medications have so many side effects. So we use various approaches, often cellular approaches, to trick the immune system with your own cells and sometimes your donor cells in a living donor situation to not require those anti-rejection medications that go through your whole body. And that's called immune tolerance. We're still in trials for that, but we have more people off anti-rejection medication than anywhere else in the world. We're in the process of starting to do targeted drug delivery trials where we design trials around some of the research that I've spearheaded, where we package these anti-rejection medications in nanoparticles and we target it to the organ, not the patient. These pillars of immune tolerance and engineering tissues, and then seeing how patients do afterwards and how we can improve their outcomes with outcomes research and obviate needs for things like biopsies with blood tests and liquid biopsies, biomarkers, and biomarker discovery really make up the pillars of the research of the Matrix program.
You've mentioned so many interesting things, using nanoparticles to deliver drugs. You're doing robotic surgeries to remove some of these organs. Tell me about the future of transplantation and where do we see things going?
The future is now. For many, many years, we were using the same anti-rejection. In fact, the current standard of care is the same anti-rejection medication that were developed by my mentors in the 1970s and 80s. The same preservation solutions that were used in the 1980s, largely the same techniques that were developed in the 1990s. And then for a long time, nothing ever moved until now. We hear about it on the news, xenotransplantation. We hear about the government looking at the United Network of Organ Sharing and seeing how they can build in more artificial intelligence. We went from 2 years ago here at Northwestern, very little percentage of our donors being done robotically, to 70% or more being done robotically. Trials that I mentioned about nanotherapy that we're on the forefront of, engineered tissues. I told you already about our tolerance trials. We run over 90 clinical trials in the Comprehensive Transplant Center. So the future's now. We are in the most exciting time of transplantation that I can imagine or remember. And I often feel somewhat like some of the early pioneers when they were trying to experiment with transplantation. Transplantation is not an experiment anymore. Making it better is what we are dedicated to doing. So we're really in that paradigm shifting renaissance of transplantation right now.
As we wrap up today, for those listening, tell us why. Why should they consider Lurie Children's and Northwestern Medicine if someone in their family needs this type of procedure?
We have been doing transplant for liver transplantation probably close to 30 years, and living donors also more than 25 years doing living donor liver transplants. In living donor liver transplantation, here in Northwestern, we were the first center in the world that performed a minimum invasive approach for living liver donation. The same for kidney transplantation, even longer. And our outcomes are excellent. We are decreasing the mortality on the waiting list to our patients, and we're improving the access to transplant care to these patients.
I just think it's really important to note that Northwestern and Lurie Children's is really on the forefront of the paradigm shifting work that's happening in transplant. I always tell people that, when at the end of my career, if I look back and I have transplanted a lot of people, that's great. I would be ecstatic with that. But on top of that, if I look back and say, wow, we changed the way transplant was done, I would be even more satisfied.
Fantastic. Well, thank you so much, Dr. Satish Nadig and Dr. Juan Caicedo, for coming on the show, for all of your insights today into this really state-of-the-art program. Appreciate it.
I had a great time. Appreciate it.
Thank you so much, Erin.
For more information, including how to make a referral or an appointment, visit luriechildrens.org.